My name is Tanios Bekaii-Saab. I'm chair and consultant with the Division of Hematology and Oncology and a professor at Mayo Clinic and practice in Arizona, on our campus in Arizona. I will be speaking about the emerging role of HER2 targeted therapy in advanced biliary tract cancers. I think it's very important to set the stage with a clear understanding that as we are moving more and more into this world of molecularly targeted therapies matched to a specific target, we're seeing across malignancies. This is not just in biliary tract, but that includes biliary tract. We're seeing significant improvement in outcomes in all our GI malignancies and non-GI malignancies. It turns out to be true. So if you find a target, you match a target therapy to it, patients do much better, and that's really what's driving a lot of the drug development beyond chemotherapy over the last few years. Now, biliary tract cancer is a very target-rich disease. Now, it's a rare cancer. It's not a common cancer. I'd say uncommon to rare, depending on what you look at. But also, when you start looking at the different anatomical subtypes of biliary tract cancer, we have intrahepatic in the liver, we have extrahepatic, and then we have gallbladder, and they seem to carry a little bit of different alterations, either amplifications, mutations, or other drivers that seem to be established there. So it's pretty target-rich disease. Molecularly, though, it may look different in the intrahepatic versus gallbladder. Say some of the more prominent targets, say in the intrahepatic cholangiocarcinoma, would be FGFR2 fusions, IDH1 mutations. HER2 amplifications more common in the extrahepatic cholangiocarcinomas and very dominantly present in gallbladder cancers as well. So we published this a while ago and looked at essentially commonly altered genes with actionable alterations. So we looked at intrahepatic cholangiocarcinoma, and you can see that if you look at IDH1 mutations, they're pretty overrepresented, about 20+%. Same for FGFR2 fusions. What you don't find as much are HER2 amplifications in the intrahepatic cholangiocarcinoma. As a reminder, intrahepatic cholangiocarcinoma account to about 50% of all biliary tract cancer in the United States, and less so if you go to the eastern part of the world, where you find more extrahepatic cholangiocarcinomas, as well as gallbladder cancer, where HER2 amplifications are actually dominant, drive a lot. In fact, with gallbladder cancer in some parts of the world, it's in 30% of patients with gallbladder cancer. So I think it's important to understand, as we do in our practice at Mayo Clinic and other practices as well, we have automatic or reflexive testing for IHC HER2 for any patient diagnosed with cholangiocarcinoma. In fact, for all GI cancers. Uh, at the time of diagnosis with metastatic disease. So we have this worked out, at least in our Arizona campus, with our pathologists. I think that's important, but we also do very reflexively blood-based next-generation sequencing, as we also send tissue-based next-generation sequencing. And the key here is to essentially have a full picture of not just, of course, HER2, but others as well. That's why you need NGS. But what we found in this study that's now published in Journal of Clinical Oncology, I was senior investigator on this study with Dr. Nakamura from Japan, who was first author. When we looked at the HER2 testing and exploratory analysis and looking at IHC versus blood-based next-generation sequencing, um, the percent agreement on the positive was close to 80%, which, by the way, we found also in Mountaineer and colorectal cancer. So the blood picks up about 80% of the patients with amplified NGS, and when you look at tissue to tissue, it's almost 100%. So that IHC plus minus FISH, when you get your answer, you get it in 2-3 days, with your pathologist, and central blood NGS in about a week. The correlation is about 80%. If it's not in blood, there's still 20% chance it's in tissue. And this is where IHC plays an important role, but also amplification on tissue next generation sequencing. Thus, the reason why we do all these. So important to keep in mind. Now, there's quite a bit of work that has been done with HER2 inhibitor strategies in HER2 positive biliary tract cancer. We started first with pertuzumab trastuzumab from the MAI pathway study, which included a cohort of a number of malignancies. One of them was biliary tract. And you can see the response rate was about 23%, and then the survival about 11 months. The paper we published with tucatinib trastuzumab in the Journal of Clinical Oncology essentially found a response rate close to 50%. And a median overall survival of close to 16 months. Now we're starting to see, those numbers looking, a little bit more favorably. But duration of response was relatively shorter than what we've seen with others. And duration of response is a bit tricky to gauge. I mean, I think more importantly, looking at the median PFS, which is a bit more accurate because it also measures stable disease. Now, with trastuzumab deruxtecan, there were a couple of studies, and I'll go through more details of those studies. One from Japan, and then the Destiny Pan tumor study, which essentially looked relatively similar, and the responses really hovered between 35 to 55%. So high response rates we see with trastuzumab deruxtecan, PFS also favorable, and duration of response very interesting. And finally, this new bispecific, so zanidatamab, which was looked at in Horizon biliary tract cancer, to a large study, again showing predictable response rate of 40%, a reasonable median PFS, but also a duration of response that was very interesting. Now you can see that the toxicities are relatively reasonable. We see more with the trastuzumab deruxtecan, and we'll talk about that a little bit more. That experience is universal, not just limited to biliary tract cancer. So this just shows, that first study that was presented by our friend Milan Javle in Lancet Oncology. This was one of the first studies looking at pertuzumab trastuzumab in metastatic biliary tract cancer, and you can see, an interesting waterfall plot. And I can tell you that it only gets better from here, with the more recent studies. I want to start with a case just to illustrate, what we see in clinic and how we manage those patients. So this is a case of a patient, 71-year-old female patient with a past medical history, frankly, of just diabetes, and then started having some right upper quadrant abdominal pain, a little bit of nausea, progressively for 3-4 months, lost a little bit of weight, presented to her primary care physician, decided to do an ultrasound. And they were worried about cholecystitis and gallstones because of the progressive nature of the pain. But what they found is essentially a number of liver lesions concerning for metastatic disease. So that elicited a CT scan, and a CT scan of the abdomen pelvis now showed a 5.5 liver mass that seems to actually arise from the gallbladder and invading into the liver, which is pretty much what we mostly see with those tumors, and what looks like carcinomatosis. In an ultrasound guided biopsy of one of the liver lesions, there were multiple. The largest one was essentially the one that was extending from the gallbladder, was biopsied, and it did look like poorly differentiated adeno consistent with gallbladder primary. Now, as I said, our institutional standard is automatically do HER2 testing once you identify a cholangiocarcinoma, and this essentially looked like a HER2 at 3+. So when you see the patient in our clinic, you already have that result on hand, which is great because that facilitates the discussion. Both blood and tissue were sent for NGS testing, and there was also confirmed HER2 amplification and no RAS mutations or BRAF mutations. Her LFTs were reasonably well preserved, except for what you would expect for an alkaline phosphatase. So we started her on gemcitabine, cisplatin, and durvalumab. She had stable disease as her best response, but at 6 months, unfortunately, she progressed. And then we decided to put her on trastuzumab and tucatinib based on the work we were doing. And just to go over the study, so this was also a basket study that cohort 3 had biliary tract cancer and allowed overexpression or amplification by blood as well. These were patients that failed prior therapy, and the response rate was the primary endpoint. The study did meet its primary endpoint, so the response rate essentially was confirmed, and you can see, the waterfall plot looks pretty nice. There was a patient with a complete response, had a beautiful response, and then a number of PRs and stable disease, and very few progressors actually on this study. So most patients had some relative disease control rate, and you can see that those patients that are more on the IHC 3 plus spectrum tend to have responses that are deeper. So the patient actually did relatively well with her treatment with only grade 1 diarrhea. It was controllable, minimal fatigue. Did a scan at 2 months. Looked like she had a great response, shrunk about 45% at that time and continued to shrink. PS was full zero, back to full activity, including golfing. You know, we're in Arizona, and so golfing is a favorite pastime, and she continues to do well. And now she's 12 months later with great tolerance and continues to have a good quality of life. And this just shows the toxicities that we've seen on the study with trastuzumab and tucatinib. Again, as we've seen with colorectal cancer and others as well, there are very few grade 3 toxicities, almost no grade 4 toxicities. Most of the toxicities were manageable at grade 1 and 2, primarily diarrhea and some pyrexia. So this is a second case. This is a patient with hilar cholangiocarcinoma, HER2 positive. This is a 62-year-old male. Again, no significant past medical history. Presents with progressive fatigue and weight loss, and then ultimately developed jaundice, as most of these patients tend to show with, and had elevated LFTs and hyperbilirubinemia. Now, the patient was sent to have an ERCP, and it showed a near obstructing mass consistent with hilar cholangiocarcinoma by cytology. Plastic stent was placed, and eventually the jaundice resolved. A scan of the abdomen shows multiple lesions in the liver, and the largest actually was 7 centimeters at the dome. This was biopsied by ultrasound guided technique and showed moderately differentiated adenoma with cholangio. Now, again, as we do in our practice, you know, this patient had HER2 at 3 plus by IHC and also microsatellite stable. And blood and tissue again were sent for NGS, confirmed the HER2 amplification. There was a G12V, like Victory, mutation in this patient. TMB was moderate, so on the lower side, and his LFT were normalized at that time. So now we started the patient on GemCis and Pembro and had actually 50% shrinkage consistent with the PR. Unfortunately, at 8 months, looked like the patient progressed in the liver and the peritoneal carcinomatosis. Now, for this patient, we decided to go with a trastuzumab deruxtecan. The problem is with HER2 amplified tumors and the presence of a RAS mutation, at least GI malignancies, or a BRAF mutation, you're less likely to see any response with agents like trastuzumab, pertuzumab, or trastuzumab tucatinib. And those patients tend to do better or tend to respond relatively well to trastuzumab deruxtecan. Makes sense because ultimately trastuzumab deruxtecan is just targeted chemotherapy, whereby the others are really just targeting the activity of the receptor itself. And just very quickly, what is trastuzumab deruxtecan? Many of you may know that. It's essentially, you know, an antibody drug conjugate. You have the HER2 antibody with a linker, and then deruxtecan, which is a topoisomerase inhibitor, which gets released in the tumor and actually have most of the effect. And trastuzumab deruxtecan, as I said, was looked at in two studies. One is essentially this Japan-only study, a smaller study, again, looking very favorable. And that makes kind of sense, right? In patients who have a lot more expression of HER2, so these are the IHC3 plus and others, you see the best responses. But you continue to see some responses with essentially the 2 plus and ISH plus. And this study did include some HER2 lows, which showed very little to no activity with the HER2 lows. And that's not surprising. We don't see that in most of our GI malignancies, that the HER2 lows don't respond as well or to almost zero to these types of agents. Now, the toxicities remain problematic with trastuzumab deruxtecan. As I showed you with the initial table, is that you do see more toxicities with trastuzumab deruxtecan than with the other HER2 target strategies. And it's mostly driven by chemotherapy-like toxicities. So you hit the white count, you hit the blood counts overall, you get nausea, you get significant fatigue. But one of the most concerning toxicities is interstitial lung disease, which appears in about 10% plus of the patients, and is certainly in many reports has led to some death or permanent disability for some patients. So this is one of the more concerning toxicities, and why sometimes the reluctance to start with trastuzumab deruxtecan. This study, the PAN Tumor 02, which led to the approval of trastuzumab deruxtecan for HER2 positive disease, essentially had a biliary tract cohort which showed a very favorable response in patients with biliary tract cancer. Again, no response in those patients with low expression of HER2, but very good response with IHC3 plus, and some moderate response with the 2 plus. Again, very consistent, what we with what we see and what we expect for our disease. And this just shows you again the median progression-free survival of those patients. This was stratified by 3 plus, 2 plus, and as you can see that the 3 plus do well, the 2 plus don't. And the same for essentially median overall survival. Those with 3 plus do really well with median OS of 12.4. Those essentially with 2 plus 6 months, and so not as well. And the toxicities again pretty predictable. Again, chemotherapy-like toxicities, and then of course the interstitial lung disease that remains a concern, a significant concern with the administration of these agents. So this patient actually, unfortunately, was one of those that experienced interstitial lung disease. So 6 weeks after the treatment, and you can see this as early as the first, I'd say about 5 to 6 weeks, but you can see it in some patients as late as a few months. Here, the patient started experiencing some shortness of breath, dyspnea, exertion, and a non-productive cough. So these were warning signs. So we checked her oxygen sats; they were 81%. We stopped the treatment immediately, and we admitted him to the hospital. And he was placed on 5 liters of oxygen with normalization of oxygen saturation. So on this patient, we did a CT scan of the chest, which showed diffuse alveolar damage with interstitial pneumonitis, pretty consistent with what you would expect with insult from trastuzumab deruxtecan. And so the patient, he was started on high dose IV methylprednisolone, and ultimately was discharged once stabilized. And I saw him in clinic 4 weeks later with a scan that suggested significant improvement, but unfortunately there was no resolution of the ILD. And unfortunately, again, he remains on 2 liters of oxygen by nasal cannula. And with that, we actually permanently discontinued trastuzumab deruxtecan as per the guidelines. Some of the examples of how these pictures may look like with interstitial lung disease and pneumonitis, and the benefits from administering IV steroids, methylprednisolone. These were picked from a paper that was recently published. Not necessarily biliary tract cancer, but across the board. And so you can see that essentially the first patient is as quickly as 2 weeks, actually, which is the fastest I've seen, developed interstitial lung disease, almost with complete resolution after 4 weeks of IV methylprednisolone, whereby the patient too essentially, developed. Started developing some of ILD around 3 months, which ultimately seemed to continue to get worse with time, but it was a minimal outcome. So, how do we manage those? Not to belabor over all this. So, depending on the severity of the disease, so at grade 1, you can actually discontinue and monitor. Will discontinue temporarily and then monitor and even restart if the patients goes back to complete normal. Most of our patients, unfortunately, will present with grade 2 and grade 3. Grade 3 is essentially literally the patient ends up in the ICU. For those patients, you have to permanently discontinue trastuzumab deruxtecan, regardless of how well they recover. So I want to move now to this very exciting new agent called zanidatamab, which is an anti-HER2, what we call biparatopic antibody. And this agent, and again, not to belabor too much over this, but has some unique capacities to induce HER2 clustering, but also seems to induce complement-dependent cytotoxicity. So a dual effect. One is a direct effect, and one is an indirect effect through essentially eliciting, at least theoretically, right, eliciting, complement-dependent cytotoxicity. And this was studied in locally advanced or metastatic biliary tract cancer in this Horizon Biliary Tract Cancer 01 study. This was a large study of close to 80 patients, including gallbladder cancer, intrahepatic cholangio, and extrahepatic cholangio. As we discussed, you're going to see most of these patients with gallbladder cancer, some with extrahepatic and few with intrahepatic cholangiocarcinoma. Very impressive waterfall plot, but also very impressive swimmer's plot, where you can see some of these patients now going to almost 2 years with a continuous response, which explains the median duration of response. So the thought here is that, I mean, we're seeing the responses we would expect with anti-HER2 target treatments, but with this agent, there seems to be more durable responses. And the thought that the durable responses are mostly driven by complement activated cytotoxicity, meaning it's one that lingers beyond just targeting the receptor itself, that may explain, and I say may because, this is all speculative at this point of time, that may explain, why we're seeing such durable responses. And the toxicities, I mean, this is relatively well tolerated. Interestingly, we do not see the what you would expect from other similar agents. We don't see any CRS like toxicities, so mostly tolerable. There was one patient with grade 3 pneumonitis that led to discontinuation, and ejection fraction decreased, which is, a class toxicity related to this class of agent, but mostly well tolerated for this. So, to finish off this, what are the takeaways and the conclusions? I think, it is clear, as with all our malignancies, that we really need to be looking for these targets. That improves outcomes significantly for patients. And in this case, next generation sequencing, liquid platforms testing is central to future applications. And I'm not just talking about HER2. HER2 is one, and IHC is one that's very reliable, and HER2 in our institution we do it automatically. But also, to look for others, because we know that's moving the needle quite significantly in this disease, and it needs to be timely. And molecularly targeted agents, specifically those targeting HER2, are really, I mean, now we see all these studies, all these agents, trastuzumab, pertuzumab, trastuzumab tucatinib, trastuzumab deruxtecan, zanidatamab, they're all providing patients with these magnificent responses that we don't, by the way, we don't even see those in chemotherapy. When you talk about a 40-50% response rate, and we think about GemCis Durva or GemCis Pembro, where the best response you see is about 25%, I mean, that's pretty remarkable with these agents. Now, we still have to learn a little bit more about drug resistance mechanisms and how can we overcome and prolong these responses, and also understand the sequencing, similar to colorectal cancer. We start with, say, trastuzumab, pertuzumab, or trastuzumab tucatinib, which is my preferred for now. Zani is not approved yet. And then as a second line of defense with trastuzumab deruxtecan, but also thinking about those patients with RAS mutations. Very few have in at least biliary cancer, unlike what we see in the 20% with colorectal cancer, have RAS mutations. Those do not respond to pertuzumab or to tucatinib. Those would be eligible for first-line trastuzumab deruxtecan. And so more to come in this uncommon disease, but seeing some really great signals. Thank you.
So that was really great. I'm looking forward to talking about it in the webinar. Just a couple of follow-up questions. You talked about, quote, the class of bispecifics, but most of the bispecifics I've been hearing about in heme are CD3 immune bispecifics where you see cytokine release. But I don't know about too many where you hit two parts of the same receptor. The one I know about is amivantamab and EGFR positive lung cancer. And they see other stuff. They have the edema, all this other stuff. So like these bispecifics that hit two pieces of the same target, particularly if the target is HER2, is there a class effect, or we really don't know about those kind of, are there any other agents other than amivantamab like this? That I don't know of any
No,
myself.
I frankly I can't think of others that are like it. That's why the toxicities are a bit different here. I mean,
Right,
this,
right,
this technically, blocks HER2, internalizes HER2, but also leads, and this is all theoretical, by the way, immune-mediated cytotoxicity. You're absolutely right. This is a bit different. It does hit two
right,
different sites of the same
right,
receptor, so a little bit
right,
different in that sense, and maybe one of the reasons why you're not seeing the toxicities that are more typical.
right. And I guess related to that, or another thing I was going to ask you about, because actually there is a CD3 bispecific now in small cell. It's called
Mhm.
tarlatamab, and that does have cytokine release. So that's like the
Yes,
bispecifics in heme that they're going to have
yes,
to figure that out in small cell, which is going to be really interesting.
and more
But
coming,
getting
more
back to,
coming. Yeah,
yeah, yeah,
more
for sure.
coming.
Yeah, exactly. There's another one that's coming along really fast. So, getting back to one of the more major questions here, which is from my point of view, what comes first, TDXD or tucatinib trastuzumab? Let me ask you, you obviously made the point about efficacy in the presence of KRAS or BRAF. Anything else which would get you to use TDXD before tucatinib trastuzumab? For example, a patient who like really needed a response, who had visceral disease, who's, really, maybe you didn't think you could get two lines in. Would you go? Do you think TDXD maybe theoretically, even without KRAS, is more effective? You might go with that first, or you still go with Mountaineer.
I still go with trastuzumab to catinib, and the reason for this
Right.
is because if you look at the IHC 3 plus, the response with trastuzumab deruxtecan is about 56-58%.
Right. Yeah.
If you look,
Absolutely.
yeah, and if you look at
They
trastuzumab
want.
to catinib, you get about the same. You get about the
Right.
same
I
when
know.
you isolate the 3 pluses.
Yeah, it's again always interesting to compare the breast people and all.
Yeah.
Anyhow, only other thing I was going to ask you about is I'm just kind of curious. Any experiences with the Mountaineer regimen and biliary that stick in your mind that were very positive? Somebody who really, maybe the patient you presented, or any other patient who had even a better response. Like, what's your best response that you've seen?
So in biliary, close to 2 years. So this one is ongoing. I don't know how long she will continue to respond. I hope, frankly, we'll reach beyond the 2 years. But 2 years was the max I've seen with trastuzumab to catinib, at least in biliary. In colon, and it's a very different story. We've had 5+ years with continuous
Huh.
response.
Really? Wow,
Yeah.
interesting. So what about TDXD and biliary? What's the best response you've seen there?
Uh, I'll be very frank. It's first of all, we're using it, post trastuzumab to catinib, or in the presence of a RAS mutation, which is an adverse prognostic element. So what you see lesser durability of responses, frankly. And so, I have not been able to get any patient beyond a year with trastuzumab deruxtecan, even in colorectal cancer. But it could be the placement. We're not using it first. We're using it second.
What about any patients who were very symptomatic, had a lot of disease, who had a lot of response with TDXD?
No, you do see a nice response with TDXT. Uh,
Like your
you,
patient who, you hear all these stories in lung of people who get PD-1 inhibitors and they get toxicity and then they never go on another treatment. Did you have to put your patient on another treatment yet?
oh,
The one
this
who
one.
got the ILD?
So this one actually ended up, ironically, getting a nice response with this. That's still ongoing. Actually, the patient is reluctant to go on more treatment, but the problem is that I don't think there will be much benefit from another targeted HER2 target strategy because of the RAS mutation. And so I think, unfortunately for him, we're done with HER2 target strategies, unfortunately. And now the good news, I do have a study coming for a 12V, and then we have these pan RAS inhibitors. So ultimately, if he continues to look good, we may consider one of the pan RAS inhibitor studies or the G12V studies for him.
Is he looking like some of these cases I've heard in lung of somebody who gets a toxicity but just keeps responding? How long has it been?
Few months, and ultimately, I think though the response, he's reached the max. I haven't seen additional improvement. So my suspicion is
Right,
that
right.
there will come the time where I'm going to need to think about alternatives, which may come very soon.
So one final question. This issue about KRAS and BRAF, does that apply to zenocutuzumab also?
Theoretically, yes. I haven't seen much of the data in the presence of RAS because it's
And the other,
targeting HER2 specifically. So you may see a little bit more of a maybe a little bit more of a response, mostly if that if that immune response is real, then you can argue that you could still see some level of response. But targeting HER2 directly, you're not going to see that response. So maybe the second piece may salvage some patients.
I guess this is kind of a naive question, but I assume you use anti-BRAF therapy in patients with biliary who have BRAF. Do you use it like first line?
Second line, and there was the ROAR study, which looked at MEC plus so trametinib and
Dabrafenib?
dabrafenib. Yes, thank you. And those actually produced up to 46% response rate,
Hmm.
and many of them were durable. So we do use it. We had a study with encorafenib and binimetinib, um, and there were others as well, smaller studies. But ROAR, the dabrafenib and trametinib is the largest, and did show, close to 46% response rate. Now, Neil, think about it. In biliary tract cancer, every time we find a target, whether it's BRAF, KRAS, because we published data on G12C with response rate up to 50% with adagrasib single agent, FGFR2 fusions, we have data, again, response rates up to 40, 50% with HER2. So anytime you find a target and you hit it, not only that you get responses, they're typically deep and durable for many patients, much beyond what we see with chemotherapy. I suspect that ultimately, and I find every reason just to be done with chemo as soon as I can so I can go to a targeted agent when I have a target, because the responses are more steep, they're more durable, and the quality of life for the patients are actually much better when we shy away from chemotherapy.